Okay, so good evening everyone. So we'll start off with our second discussion. This is the second topic sa atin midterms. Actually, sobrang daming topics tayo sa midterms pero gintanggalan ko na lang yung iba. So probably we're going to talk next meeting about ang tawag dito, the female genital tract na diseases, no? So baka amulan na. And then the last topic will be the autopsy. So for today's lecture, we're going to discuss about pag-usapan natin si heart. Okay, may chismis kasi kay heart. Hindi, joke lang. So our topic for today or for this evening is about heart. All right? So very easy lang ito. I mean, I hope na this is mabilis lang siyang intindihin. All right? So before we discuss about the abnormalities of the heart, we're going to discuss or to review first the anatomy of the heart or yung flow lang ng blood, no? Kasi this is very important for our discussion. So this is the normal structure of the heart, just to show you the movement or the outflow of the blood. So this is the superior vena cava. This is the inferior vena cava. The blood coming from the upper part of the body goes here, and the blood coming from the lower body parts will go to your inferior vena cava, superior vena cava. They will converge and they will throw blood to your right atrium. So makita natin pag blue, this is the oxygenated blood. So right atrium, okay, and it passes through the tricuspid valve. So it separates the right atrium from the right ventricle. So blood from the right atrium will go to your right ventricle, after which it will go to the main pulmonary artery or the main pulmonary trunk, which will divide further into your right and your left pulmonary arteries. But before it goes to your main pulmonary artery, it must pass through this valve. This is the pulmonary valve or pulmonic valve. So after which oxygenate yung blood natin. So baliktad siya, no? Kasi this is artery but this is deoxygenated blood. So ito yung pinagkaiba na with the rest of the systemic arteries, all right? Or the muscular arteries in the body, no? Baliktad siya. Artery is the oxygenated blood, the pulmonary artery. Then it goes to your lungs. So papasok na ito sa lungs dito, sa right and the left lung, where the blood will be oxygenated, and then ang oxygenated blood will go back to your heart via the pulmonary veins. Okay, ito yung mga pulmonary veins natin. Alright, then the pulmonary veins carry your oxygenated blood, itong pula. So pupunta siya ngayon sa left atrium. Okay, sa left atrium, pupunta siya sa left ventricle via the mitral valve. Alright, and then from the left ventricle, it will go to your aorta via the aortic valve here. All right, and then the oxygenated blood from the aorta will go through the different parts of the body, depending to the three branches of your aorta, and will go down to sa iba't ibang part ng katawan. Kasi yung aorta natin mahaba yan up to the thoracic aorta, abdominal aorta. All right. So yun yung flow natin ng blood. So this is very important because in your congenital heart diseases, so very important yung flow of blood, kung yung oxygenated ba itong blood, paano yung oxygenation ng blood, kung magmi-mix ba siya or not. Alright, so let's start off first with the disease of the heart. So remember that although different diseases can affect the cardiovascular system, yung pathophysiology pathways of the diseases of the heart are broken down into the following or 6 principal mechanisms, namely, number 1 is failure of the pump, since the blood is pumped by the heart. All right, so merong failure of the pump, merong obstruction of flow. So remember, isang flow lang yan. This is a one-way flow lang. So ibig sabihin, forward flow lang siya, walang balik-balik or walang reverse flow. So there is obstruction to the flow of blood. There can be regurgitant flow. So pag merong obstruction to flow, there can be a regurgitant flow. Pag ibig sabihin ng regurgitant flow, nagbalik. Okay, merong backflow. Alright? Next is shunted flow. Pag sinabing shunted flow, may ibang dinaanan due to a defect in the heart. May butas sa heart, for example. So nag-shunt yung the usual flow, the normal flow of blood is shunted because there are some abnormalities intrinsic to the heart structures. All right. Next is your disorders of cardiac conduction. Okay, remember that before the heart will pump, before yung muscle mag-pump, kailangan may electrical activity yan. All right, through our mga pacemaker system. So pag mayroong problema dyan, eventually meron din problema sa contractility and therefore the pumping of the blood to the different organs. All right. Next is your rupture of the heart or major vessel. So in cases of myocardial infarction, one of the complications of MI is your aneurysm, and eventually, pag hindi na talaga makayanan, it can rupture actually. And also for the major vessels, aside from the pwedeng mga traumatic events or traumatic injury, this can also rupture the heart, or pwedeng iatrogenic during operation. This can rupture the heart and your major vessels. So first, we're going to discuss about heart failure. So pag sinabi nating heart failure, nag-fail ang heart, so hindi ka na makakapag-pump ng dugo. So it is a condition in which the heart cannot pump blood to adequately meet the metabolic demands of peripheral tissues, or can do so only at elevated filling pressure. So kung hindi nakakapag-compensate, kung hindi makaka-receive ng oxygen yung peripheral tissues natin, so ang ginagawa is that it can elevate the filling pressures of the heart. Siyempre, pag mataas na yung pressure ng heart, ano mangyayari, di ba? We have the pathologic hypertrophy. All right? Mag-a-adjust yung heart. But this is a pathologic mechanism. This is pathologic hypertrophy of the heart. Kasi there is problem in your pumping. Okay? May problem sa ating contractility. And remember that when cardiac workload increases or cardiac function is compromised, there are several mechanisms that are put in place to initially maintain arterial pressure and organ perfusion. We have the Frank-Starling mechanism, activation of neurohumoral responses, and myocardial adaptation. So ito yung myocardial adaptations, ito yung sinasabi kong hypertrophy. The Frank-Starling mechanism is the recoil of the blood, or the recoil of the muscle tissue when there is elevated or increased in pressure sa heart natin. All right. Then activation of neurohumoral responses. So we have atrionatriuretic peptide na kailangan minsan pag there is decrease in decrease in blood volume. All right. So meron tayong mga mechanisms before eventually magkaroon ng failure sa heart natin. Okay, what is cardiac hypertrophy? As I have said, this is an adaptation of the heart. Okay, so this is most likely a pathologic adaptation. So if there is a sustained increase in mechanical work of either the ventricle due to pressure overload, okay, or volume overload, or trophic signals that are mediated by the following, it can cause myocytes to hypertrophy. So pag sinabi nating hypertrophy nga, anong pinagkaiba niya sa hyperplasia? If you can recall our previous discussion, what is the difference between hypertrophy and hyperplasia?
Ang hypertrophy, Doc, sa size, while ang hyperplasia sa numbers ng cells.
Okay, very good. So, pero eventually yung hyperplasia, since dumami na yung mga cells natin, yung main mechanism niya is dumami yung cells. So madami, there is increased production of cells. So eventually maglalaki din yung size niya. Pero you are correct, no? So the underlying problem with hypertrophy is that there is increase in size of your cells. So ganun yung mangyayari natin since the heart is a permanent permanent tissue, considered permanent tissue. Hindi naman siya nagre-regenerate unlike your liver, no? All right. So there are two patterns of your hypertrophy. This is dependent on the type of mechanical work. For example, if there is pressure overload and if there is volume overload. Pag sinabi nating pressure overload, ibig sabihin ang mangyayari, actually they do, or they go hand in hand, no? Kasi pag mataas if there's volume, eventually there is increase in pressure din, all right? Pero pag specific yung pressure, there is concentric increase in the wall thickness, all right? So concentric increase, ibig sabihin, imagine mo yung hose, okay? Ang hose natin. So pag may concentric, syempre concentric yung formation natin. So pabilog din ang ang thickness, ang pag-thicken ng ano natin, ng heart or ng myocardium. With regards to volume overload, anong nangyayari? There is ventricular dilatation. Okay? So, ito ngayon, numinipis. Okay? Numinipis yung ano natin, yung myocardium. Alright? Kasi secondary to dilatation. Pero actually, hindi naman talaga siya naganipis. I mean, relatively, naganipis niya kasi dadako ang iyang volume. So, parang it seems like the myocardium is thinned out. Okay? Kasi nag-dilate siya. All right? But the pressure, tandaan niyo lang yung pressure overload, there's concentric wall hypertrophy. Okay? Pabelow. All right? So ito yung differences between the heart failure. This can be divided according to the what kind of the laterality of the heart. So whether left-sided or right-sided. So meron kasi tayong right atrium, the right heart, right atrium, right ventricle, left atrium, and left ventricle. So pag sinabi ng left-sided heart failure, so ito yung nasa affected yung left atrium and left ventricle. Lahat ng pulmonary circulation, ganun. Part siya dun eh. If you can recall kanina yung blood flow natin, all right? So remember that the left-sided heart failure most oftenly caused by ischemic heart disease, hypertension, aortic, and mitral valvular disease. So ito yung mga valves natin present in your left heart, all right? Sa aortic, okay, remember, aortic, left ventricle to aorta, and your mitral valve, left atrium to left ventricle, and primary myocardial diseases of the left heart. Okay? And remember, pag merong failure or merong left-sided heart failure, anong mangyayari? Okay? So, ibig sabihin, wala. Pangit yung contractility ng left heart mo. Hindi ka makapag-pump ng blood forward to the circulation or to the systemic circulation para ma-provide yung oxygen sa mga organs natin. So, anong mangyayari? There will be leakage or there will be backflow of the blood back to the kung saan yung next niya na kung saan yung before na lugar, okay, which is the lungs, correct? So left atrium or left ventricle magba-backflow to left atrium, magba-backflow to the pulmonary circulation. So there is passive congestion, the stasis of blood in the left-sided chamber. So medyo static na yung blood flow natin, all right? So there is prone ka mag-develop ng thrombus, all right? Kasi may stasis of blood flow eh. And inadequate perfusion of the downstream tissues. Siyempre nag-stagnant na yung blood mo. So hindi ka na makakapag-provide ng oxygen to the forward organs, all right? So therefore there is pulmonary congestion kasi nag-backflow sa imong lungs, no? And edema with the presence of hemosiderin-laden macrophages, which are also known as your heart failure cells. So very clear on that. Pag left-sided, yung manifestations usually sa lungs, all right? When we say right-sided naman, so ano yung immediately before the left heart? Of course, before the left heart, nandoon yung systemic natin, all right? Nandoon yung veins natin, all right? So nandoon sa body, all right? So this is caused usually by a left-sided heart failure. So kumbaga, train of events, no? Nag-fail yung left heart mo, nag-fail din yung pulmonary circulation, eventually babalik matatapon yung yung abnormality back to the right heart. Okay, as any increase in pressure in the pulmonary circulation from left-sided heart failure inevitably burdens the right side of the heart. All right, and then of course, as I have said, kung ano yung immediately before the right heart, nandoon yung problem natin or nandoon yung manifestations, which include your peripheral edema kasi nag-stagnate na eh. Okay? Mataas na yung pressure sa imong right heart. So, ang blood hindi nakapunta sa back to the right heart. Okay? Back to the or mag-forward pumping of the blood. So, ma-retain yung blood into the circulation. Okay? Systemic circulation, magkaroon ng edema, visceral congestion, magkakaroon ka ng mga ascites, for example, or magkakongest yung liver mo, for example. So, more on the right-sided heart, sa systemic yung effect nun. All right? Very clear on that. Next, we go to your congenital heart disease. When we say congenital heart disease, this refers to abnormalities of the heart or great vessels that are present at birth. Okay? So remember, during embryogenesis, okay, at the 3 to 8 weeks age of gestation, na kung saan yung major cardiovascular structures nagde-develop, doon nag-a-arise usually ang congenital heart diseases natin. And remember that it is divided into major functional abnormalities. So they can be, is either a left to right shunt, a right to left shunt, or obstruction. So pag sinabi nating left to right shunt, forward yung ano. So from left heart to the right heart. So ibig sabihin nito, ang ibig sabihin nito pag left, so this means that oxygenated to deoxygenated part of the heart. Okay? Pag sinabing right to left shunt, ibig sabihin may shunting or merong pathway or merong daanan na from the right to left side of the heart. Ibig sabihin from deoxygenated blood nagkadto siya sa oxygenated blood. Okay? Or nagmix siya sa oxygenated blood. And lastly, the obstruction. So remember that ito yung mga subtypes of our left to right shunt, right to left shunt, and obstructive lesions of the heart. So when we say left to right shunt, again, ito yung mga under nito, all right? So ito yung mga main, no? mga major types of your left to right shunt congenital heart disease. First, we have atrial septal defect. We have the ventricular septal defect, the patent Ductus arteriosus. So remember the letter D, no? Nandun yung mga D niya, all right? Whereas your right to left shunt, we have the triple T's, no? Or lahat yung may mga T, okay? Tetralogy of Fallot, transposition of great arteries, tricuspid atresia. Siguro ito lang yung tatandaan nyo. The rest, kahit wag na, okay? Kasi pag sinabi mong may D naman, oh, may D man to, oh. Basi masala ka mo da, ha? So ito na lang tandaan nyo. So lahat ng mga may T, right to left shunt. Ibig sabihin, deoxygenated blood will mix with your oxygenated blood. While your obstructive lesions, coarctation of the aorta, we are going to discuss them briefly one by one. Okay, first is your atrial septal defect. Now, what is atrial septal defect? From the word itself, atrial septal defect. So, ibig sabihin, yung septum kasi, okay, in a normal heart, ito yung septum which will separate your right atrium from your left atrium. So, anong nangyayari? So, yung may defect dito sa septum natin. So, what is it? Abnormal fixed openings in the atrial septum, this one, caused by incomplete tissue formation that allows the communication of blood between the left and the right atria. Okay, so remember that ASDs, depending on the size, pag maliit lang, no? ASDs are usually asymptomatic until adulthood. So sometimes, pag maliit lang talaga na wala namang problema, okay, sometimes hinahayaan na lang. Okay, medical management na lang. It's either yung pumping ng blood, it will, mga inotropes natin, okay? So, ang mangyayari, kasi asymptomatic, why? Because, remember, so from left to right shunt, di ba? So, oxygenated to right to deoxygenated. So, magmi-mix yung oxygenated sa mga deoxygenated. So, ibig sabihin, walang problema sa oxygenation ng blood. It can move forward yung oxygenated blood natin. Kaso may backflow lang. So, depending on the size nga, it can be asymptomatic. Pag large na talaga, syempre magkakaroon ng pwede mag-hypertrophy yung yung right ventricle mo kasi madami ng volume na pumupunta sa right ventricle mo. Pero regardless, still minamanage pa din to pag may symptomatic, may symptoms yung pasyente natin. Alright? So very easy, no? Okay, left to right shunt. Lahat ng may D. Okay? Next is your ventricular septal defect. So yung ventricular septal defect, so syempre, sa taas yung atrium natin, sa baba yung ventricles natin. Okay? So ibig sabihin may butas. So this is normal heart, all right? So yeah, these are incomplete closures of the ventricular septum. Ito normally it should be like this, no? Walang butas-butas, walang buho. So ito yung ventricular septal defect. Depende sa types, no? Hindi na natin i-discuss yung mga types ng ventricular septal defect. Okay? May intramembranous, etc., muscular, septal, etc. Alright, so hindi na natin i-discuss to. Basta ito yung ventricular septal defect natin. May buho sa ventricular septum. Okay? So remember that they are the most common form of CHD, yung VSD. Diba? Usually pag nakita natin mga bata or mga kapitbahay, may buho ang heart ni Toto. Alright? So, bawal siya mapagod. Hindi siya pwede magsagot ng modules kasi may buho yung heart niya. Okay, VSDs are classified according to their location and magnitude as I have said, but this is no longer kasi medyo ano na yun, no? Medyo complicated na siya. Okay, basta ventricular septal defect may buho. Again, in a normal heart, of course, it's the left ventricle or the left heart ang always mataas yung pressures. So remember that yung pressure kasi pressure, I don't feel any pressure right now. Yung pressure kasi, yung pressure gradient, pag sinasabi yung pressure gradient, ibig sabihin, ang flow ng pressure is that from a high to low pressure, ganun yung movement ng flow natin ng blood, alright? So, and normally, the right heart is lesser compared to your left heart. So, yung left heart, yung mas mataas yung pressure kasi ito yung magpapump blood towards the systemic circulation which is also high in pressure. Okay? So, ibig sabihin, kaya normally, yung left ventricle natin is thicker compared to your right ventricle due to that pressure gradient. So, ang movement ng blood natin is from the left ventricle to the right ventricle. Alright? So, that's from the left to right shunt. Next is your PDA or patent ductus arteriosus. Okay, so what is patent ductus arteriosus? PDA account, kasi normally yung patent ductus arteriosus, normally present talaga siya at birth. No? Magkuklose lang yan siya eventually. Okay, secondary to hypoxia. So magkuklose yan, magkuklose yan in the event na merong tissue hypoxia pag napanganak na yung baby na hindi na siya mag-aasa sa maternal circulation. Pero in some cases, okay, it can persist, no? Ito yung patent ductus arteriosus which accounts for 7% of cases of CHD and 90% are isolated defects. And remember that it can produce a characteristic continuous harsh machinery-like murmur. Pag murmur, ito yung maririnig natin sa stethoscope. So iba-iba yan, malalaman yan doctors kung anong klaseng yung murmur niya. So pag machinery-like, parang ara ka sa factory, so that could be indicative of your patent ductus arteriosus. And again, it can cause a volume overload, okay, and poor respiratory support. All right. So ito yung oxygen-rich blood, no? So from the aorta kasi, so magba-backflow siya into the pulmonary artery. Kasi may pathway doon or may shunt doon, no? From the aortic na balik na siya. Kaya meron tayong volume overload. Alright, so ganon ang patent ductus arteriosus, so remember that. Pag nag-involute pala yung patent ductus arteriosus natin na normally occurring in a normal na tao, okay, magiging ligamentum arteriosum yan. Alright, just a tiny ligament lang siya. Okay, so next is your Tetralogy of Fallot. So again, Tetralogy of Fallot, this is now, this is right to left shunt. Alright? So ano yung Tetralogy of Fallot? So sinabing tetralogy, there are apat na cardinal features of TOF. So we have number 1, VSD. Ito. So may butas ang ating ventricular septum. So there is connection now between the left ventricle and the right ventricle. Oh, wait lang. Sabi mo right, pag T, right to left atrium, tapos yung left ventricle natin is mataas yung pressure, dapat left to right. Ang mangyayari kasi, there is subpulmonic stenosis. So meron number 2, ito yung subpulmonic stenosis here. So ibig sabihin, maliit yung daluyan ng blood going to the pulmonary circulation. So ano mangyayari? So mataas na yung pressure, kailangan mag-pump further yung right ventricle mo para pumasok siya sa maliit na butas. So, ang mangyayari, ito na yung number 4. Magkakaroon siya ng right ventricular hypertrophy. So, sobrang kapal na yung right ventricle in the sense that mas mataas na yung pressure niya compared to your left ventricle. So, that's why magiging right to left shunt siya kasi makapal na yung right ventricle, mataas na yung pressure dito. And also, there is an aorta that overrides the VSD. Ibig sabihin, the aorta is immediately above the ventricular septal defect. So kaya siya right to left shunt because there is already right ventricular hypertrophy secondary to the effect from the pulmonary or the pulmonic stenosis here. All right. So that's Tetralogy of Fallot, VSD, pulmonic stenosis, overriding aorta, and right ventricular hypertrophy. Next is your transposition of the great artery. So remember, ang pathway natin, di ba? In a normal heart, we have the right atrium, right ventricle, pulmonary artery, okay? The left atrium, the left ventricle, and then the aorta. So pag sinabing transposition of the great arteries, nagpalit sila ng yung great arteries, nagpalit ang aorta tsaka pulmonary artery. So ito na ngayon, na ano nang mangyayari? This is the right atrium, right ventricle, tapos biglang aorta na. Alright? So, there is a ventricular arterial discordance in which the ventricular outflow goes to the wrong outflow vessel. Okay? So, ang pinaka-common dyan is the dextro-TGA or the DTGA, in which the aorta arises from the right ventricle. So, ito yung DTGA natin. Okay? And the pulmonary artery emanates from the left ventricle. Okay, this is the classic example, which is the more common. So, anong mangyayari, no? The outlook of infants with DTGA depends on the degree of blood mixing. Siyempre, mag-mix yung blood. Ano ba yan? Okay? Pero usually, meron diyang, ano tawag dito, parang tinadhana talaga. Pag meron ang transposition of great arteries, usually there is a defect somewhere na para ma-oxygenate somehow yung blood. So, it's either mayroong ventricular septal defect, okay, that can maintain the oxygenation of the blood. Pero, depending nga on the magnitude of tissue hypoxia, yun yung prognosis ng pasyente natin. Kaya kailangan i-correct siya. Pag, if the degree of hypoxia is greater than the degree kung saan makapag-provide siya ng oxygen to the tissue. So, ina-evaluate ito. Usually makikita natin ito yung mga pasyente na naga-blue na yung naga-blue or purple na yung natin. Purple yung bibig, purple yung makikita mo talaga yan na very pale, tapos pag umiyak na purple na yung labi. All right? So that's transposition of great arteries. Nagkabaliktad ang imong great vessels. All right? Next is your tricuspid atresia. This is still the right to left shunt. Remember yung mga T natin. So we have TOF, TGA, and TA or tricuspid atresia. Ano naman yung tricuspid atresia? So, pag sinabi na atresia, hindi na nag-develop ang tricuspid valve natin. So, dapat may valve yan, may daluyan. Ito, wala na. Okay? So, wala na siya. So, ano mangyayari, no? Tricuspid atresia represents a complete occlusion of the tricuspid valve orifice resulting from an unequal division of the atrioventricular canal. So, wala tayong daluyan ng dugo. So, ano mangyayari? Cyanosis is present virtually at birth. And there is a high mortality. So, wala nang daluyan ng dugo, no? So, cyanotic talaga siya kasi hindi ka magpo-flow yung blood yon, okay? Pero usually, there is usually a VSD. As I have said, pag meron kang mga defect, usually may associated ka ding other congenital defects such as this one, no? All right? So, ang mangyayari is that the blood from the right atrium, kasi wala na siyang pathway, pupunta siya kasi may defect na diyan, no? May ASD ka na para tawag dito, para somehow ma-oxygenate pa din naman ang blood to some extent, all right? So syempre wala kang butas diyan, so meron ka ASD, so ginawan ka ni Lord ng ASD para somehow mag-prolong ba yung life mo. Pero eventually meron pa din high mortality pa din if hindi siya na correct surgically. All right? So ang mangyayari is that the oxygenated blood will go to your left atrium. So left atrium kadto na siya sa aorta. So wala kang oxygen. Okay? Makaka-oxygen ka lang through this tiny defect here, which is your VSD. So pagpasok sa VSD, yun lang yung the time na ma-oxygenate yung blood. Pero maliit lang kasi yan. Maliit lang yan. This is not enough for the blood to be oxygenated para makapag-provide ng oxygen sa katawan. Kaya, very high yung mortality ng patients with tricuspid atresia if not intervened at the early or the soonest possible time. Okay, next we go to your obstructive lesions. First, ito lang, first and last. So, coarctation of the aorta. So what is coarctation? Coarctation is narrowing or constriction. Alright? So ito yung aorta natin. So dapat yung caliber nito is the same as to the whole length of your aorta. Pero with coarctation, ito may constriction or narrowing. Alright? So it is twice common in males as is in females. Okay? And females also with Turner syndrome are also frequently affected. So ano mangyayari pag meron kang coarctation dito? Syempre mataas yung pressure, di ba? Kasi maliit na yung ano eh. So ibig sabihin, mas mataas yung pressure, mas higher yung blood pressure sa taas, upper, for example in this case. So mataas yung pressure sa upper body. So sometimes ma-feel mo na merong nagapitik-pitik ang imong ugat sa ulo. Okay? Due to your coarctation. While yung dugo mo sa baba, sa lower circulation, kaya parang pulseless yung, ano yun, wala kang pulse sa imo nga lower extremities kasi nga, konti lang yung blood nagakadtotoo. Alright? So, yun yung manifestations ng coarctation of your aorta. So, this must be corrected. Okay? Kasi nga, very poor yung ano natin, hindi din makakasupply ng oxygen to the organs, to the part of the body that are distal to your coarctation. Kaya it must be corrected too. Okay, now we are done with your congenital heart disease. We go now to your ischemic heart disease. Remember that hindi natin ito ma-discuss lahat. Okay? So ginpili ko lang ang mga high yield, no? So ischemic heart disease, what is ischemic heart disease? Okay, ischemia, decrease in oxygen, okay? Decrease in blood flow. Represents a group of related entities resulting from myocardial ischemia in which there is an imbalance between the myocardial supply or perfusion and the cardiac demand for oxygenated blood. And it can also present with the following. It can either be a myocardial infarction or MI, okay, in which ischemia causes frank cardiac necrosis, which is fatal if not identified the soonest possible time. Next is your angina pectoris, or literally known as chest pain. So ito usually yung mga consults natin sa ER, no? Yun yung nakikita talaga natin. In which, ischemia is not severe enough to cause infarction, pero meron ka lang symptoms that can further put you at risk for impending myocardial infarction. Kaya pag may sakit talaga sa parang tinutusok na punta agad sa, or tinutusok, parang dinadaganan, ganun. That's how yung angina pectoris natin, no? Parang dinadaganan, or sometimes parang tinutusok kasi may mga differential diagnosis tayo dyan. Pwedeng costochondritis lang, alright? Or MI. Pag MI kasi parang dinadaganan daw yung chest, no? Next is chronic IHD with heart failure, and number 4, sudden cardiac death, okay? But we will only focus on the myocardial infarction. So, speaking of myocardial infarction, we are required to know kung ano yung mga blood vessels that supplies the heart. So remember that we have arteries that supply different parts of the body or different parts of the organ. Yung heart naman, kailangan din yan ng oxygen supply, and that is through the coronary arteries. All right? So ito yung aorta. Remember, di ba? Aorta carries the oxygenated blood. So some of the blood from the aorta, ito, nagfo-flow siya or nagbibigay siya ng oxygen, or may blood flow din dito sa coronary arteries natin. So this is the right coronary artery. We have the left coronary artery, left anterior descending, the circumflex artery, circumflex kasi iikot yan siya sa may left side of the heart. So depending on the tributaries of the arteries, it can supply to different parts of the heart. Alright, so depende kung saan siya. For example, pag sa left anterior descending, kung may problema, kung may infarction dyan, or may bara sa ugat, so usually the left ventricle ang affected. Okay, so MI, or almost commonly referred to as the heart attack, is the death of the cardiac muscle due to prolonged ischemia. So prolonged ischemia, kaya very important yung time natin kasi based from this table, no? Pag onset of ATP depletion, kasi wala ka ng oxygen, in seconds lang yan. Kasi at the molecular level, ma-feel agad yan ng system natin, uy, wala tayong ATP. So that's just in a matter of seconds. And then eventually, in less than 2 minutes, ma-feel na yan. So ano na yan, parang cumulative na yan, no? Loss of contractility. And then ATP is reduced to 5% of normal, and then eventually 10% of normal in a matter of 10 and 40 minutes. And there's irreversible cell injury. Pag reversible cell injury, hindi na talaga yun masasalvage. So eventually magne-necrose na yan. And then eventually it will become a fibrosis. Okay? So remember, pag fibrosis, wala na siyang contractility function. Okay? And then, in a matter of 20 to 40 minutes, kaya ito yung time natin na kailangan talaga siyang dalhin sa ospital. Pag may ano talaga, pag merong signs and symptoms na masakit yung ano, parang yan na nagganan yung puso, kailangan talagang idalhin agad sa ospital. Alright? So the earliest detectable feature of myocyte necrosis is disruption of the integrity of the sarcolemmal membrane, allowing intercellular macromolecules to leak out of necrotic cells in the cardiac interstitium and ultimately in the microvasculature and lymphatics, which is the basis of your chemistry test, yung mga cardiac markers natin, ng mga troponin, all right, troponin, CKMB, all right, which is I think na discuss na to sa CC, sa clinical chem. Okay, so there are different patterns of your infarction. This can be submural, subendocardial, or multifocal microinfarction. So ang pinakapangit dito is the transmural infarction in which buong wall thickness, okay, buong wall thickness ng myocardium mo is affected, and therefore ito yung pinaka-dreaded complication niya is myocardial infarction, and eventually pag hindi naagapan can cause death. Okay. We also have subendocardial non-transmural infarction. Okay, so occur as a result of plaque disruption followed by coronary thrombus and becomes lysed. Okay, so naagapan to either therapeutically or spontaneously before myocardial necrosis extends the full thickness of the wall. So pwede siyang by therapy, kaya kailangan agad-agad nating dalhin agad sa ospital anything na nafe-feel ng someone natin, no, ng loved ones natin, sa mga parents natin, pag nafe-feel siya hindi makahinga, parang dinadaganan na, huwag nang magpatumpik-tumpik pa. Okay, so this is the evolution of the morphologic changes in myocardial infarction. So this is in your notes. So yung ano natin, yung golden time natin, so dapat less than, okay, less than 30 minutes. Kasi from that time on, pwede pang ma-salvage yung heart or pwede pa siyang ma-save. Okay? So that's the reversible injury pa lang, no? And then eventually, tandaan nyo dito, so dense collagenous scar. So there is already, pag more than 2 months, there is scarring of the heart. Okay? Scarred heart. So hindi na yung makapump. So most likely, the patient is on maintenance na for inotropes. Okay? So the mga consequences and complications of your myocardial infarction. First is your contractile dysfunction. Siyempre, kasi affected na yung myocardium mo, which is the functional unit for the contraction of the heart. No? We have the papillary muscle dysfunction. Yung papillary muscle natin, ito yung naka-connect yung ating yung chordate tendinae ng ating mga valves. Okay? So pag na-dysfunction yan, so pwede ma-affected din yung blood flows. There can be regurgitation of the blood, all right, which can cause further failing heart. Okay, next is your right ventricular infarction. Okay, myocardial rupture. All right, we also have arrhythmia, pericarditis, chamber dilatation, mural thrombus, ventricular aneurysm, o syempre ventricular aneurysm kasi nga hindi na siya contractile, matigas na siya, fibrotic na yung heart mo. All right, and then progressive heart failure in the long run. Okay, next we go to your valvular heart disease. So first, we are going to briefly show you the heart valve. So ito yung mga valves natin. So for the right heart, we have the tricuspid valve, and then the pulmonary valve or pulmonic valve. We have the mitral valve here, and then the aortic valve here. Remember that yung mga valves natin na problematic can be replaced by your either mechanical valves, pwedeng porcine, or pwedeng valves galing sa baboy, okay, mga biologic valves natin, or mechanical valves na steel. In patients with valve replacement, they require lifelong warfarin, okay? They require lifelong anticoagulation. Kasi at risk sila of developing thrombosis. Okay, so remember that valvular disease can come to clinical attention due to either stenosis or insufficiency or regurgitation or incompetence or both. Okay, so the most frequent causes of your major valvular heart disease or valvular lesions are as follows. We have aortic stenosis, aortic insufficiency, mitral stenosis, and mitral insufficiency. Pag aortic stenosis, syempre matigas or calcified ang imo nga aortic valve. So pag calcified yung aortic valve mo, ano mangyayari? Hindi makapag-flow hindi makapag-move forward yung blood mo towards the circulation or towards the systemic circulation. Okay? It can be either a congenitally bicuspid aortic valve. Okay, usually prone sila sa calcification and sclerosis. When we say aortic insufficiency, there is dilatation of the ascending aorta. Okay. And often secondary to hypertension and or aging. So ito magbabackflow yung blood natin. So can cause further failing of the heart. When we say mitral stenosis, the most common cause is your rheumatic heart disease, which we're going to discuss later in a bit, no? Mitral insufficiency, myxomatous degeneration of the mitral valve or mitral valve prolapse or left ventricular dilatation due to ischemic or non-ischemic heart failure. All right? So yung mga valvular heart diseases natin. All right. So we're going to talk about rheumatic fever and rheumatic heart disease. So what do you know about rheumatic fever? So rheumatic fever is an acute immunologically mediated multi-system inflammatory disease classically occurring a few weeks after a group A streptococcal pharyngitis. So yung problem, yung defect dito is that there is molecular mimicry. So ibig sabihin, yung streptococcal antigen, yung group A streptococcal antigen mo, they look the same. Okay? Parang nagmimimic itong group A antigens natin or nagmimimic yung heart antigens natin, yung self antigens natin sa heart para kamukha siya ng group A streptococcal pharyngitis. So as I've said, so since this is an immunological mediated, immunological mediated, so the antibodies destroy, okay? The antibodies destroy, dapat akala niya group A streptococcus, akala niya heart yun, akala niya group A streptococcus yung heart, so doon siya nag-effect sa heart. Okay? Doon siya nag-attack. So it can cause rheumatic fever. And eventually, yung rheumatic fever natin, if it permanently destroys your valve, it can cause your rheumatic heart disease. Okay? This is characterized by a deformed fibrotic valvular disease, particularly involving the mitral valve, brought about by the permanent damage by your rheumatic fever. So remember that in rheumatic fever, there's a distinct lesion in the heart known as your Aschoff body. So this is Aschoff body, which is composed of your lymphocytes, plasma cells, and plump macrophages called the Anischko cells. So these are macrophages, also known as your caterpillar cells, because yung chromatin niya is parang caterpillar. Okay? Parang caterpillar. Parang ano lang, parang inchik ba? Alright? Parang hindi naman siya mukhang caterpillar, parang ano man siya, para siyang tae. Okay? So, rheumatic fever is characterized by a constellation of manifestations kasi as I have mentioned earlier, this is a multi-system, immunologically mediated defect or disorder. All right? So, it can be migratory polyarteritis, pancarditis, ibig sabihin ng pancarditis lahat, ng myocarditis, pericarditis, and endocarditis throughout the transmural portion of the heart. We also have subcutaneous nodules, erythema marginatum, Sydenham, chorea, OPA. Okay? A neurologic disorder with involuntary rapid movements. Next is your infective endocarditis. Okay? Infective endocarditis, from the word itself, infective. So this is a microbial infection of the heart valves or mural endocardium that leads to formation of vegetation. So vegetations, they are friable growth, okay, sa imo nga mga valves, okay, composed of thrombotic debris and organisms associated with destruction of underlying cardiac tissue. So parang ang itsura nito parang daw ginakaon ng imo nga valves sang organisms at the same time ng thrombotic debris. So this can either be an acute IE or subacute IE. Yung acute IE natin is caused by infection of a previously normal heart valve by a highly virulent organism such as your Staph aureus that rapidly produces destructive lesions. All right. While your subacute IE is characterized by organisms with lower virulence such as your virulent streptococci that cause insidious infections of deformed valves with overall less destruction. So mas pangit yung, mas destructive yung acute IE. So usually Staphylococcus aureus. So very particular ako dyan na aureus acute, okay? While your subacute viridans, the less the less invasive or less virulent. So vegetation in the heart are the classic hallmark of your IE. Ano ba yung vegetation? So vegetations are yan, yung mga vegetations natin, these are friable, bulky, potential destructive lesions containing, again, fibrin inflammatory cells, bacteria, or other microorganisms, can be fungal, pwede yun. Alright? So ito yung itsura niya. Pag RHD, dito lang siya. Pag IE, destructive talaga, especially for acute IE. NBTE, later we're going to discuss, these are the non-infective, the Liebman-Sachs endocarditis. Ito yung itsura niya. So, on the other side of the leaf, pwede siya. Okay? So ito yung mga sinasabi ko kanina na non-infected endocarditis. Now this is not associated with microorganisms. So first we have the non-bacterial thrombotic endocarditis or NBTE. This is characterized by deposition of small sterile, kaya sinawag siya non-infected or sterile vegetation on the leaflets of the cardiac valves that is often encountered in debilitated patients with cancer or sepsis, hence the previous term as Marantic endocarditis. So tandaan nyo ito, si Marantic, si NBTE. Okay. While your Liebman-Sachs disease or endocarditis of systemic lupus erythematosus, so remember, yung ano niya, pwede siyang makita sa other side of the leaflet of your valve. The lesions develop as a consequence of the immune complex deposition with activation of complement and recruitment of the FC receptor-bearing cells. All right? So, autoimmune, kasi SLE is an autoimmune disease, all right? So, non-infected or sterile endocarditis are your NBTE and your Liebman-Sachs disease or your endocarditis of your SLE. So, next we go to your cardiomyopathy. This is the second to the last topic. So, what are cardiomyopathies? These are heterogeneous group of diseases of the myocardium associated with mechanical and or electrical dysfunction that usually exhibit inappropriate ventricular hypertrophy or dilatation under due to variety of causes that are frequently genetic. So most of the cardiomyopathies are genetic diseases, all right? And sinasabi itong inappropriate ventricular hypertrophy kasi sobra is either extreme yung hypertrophy or dilatation nila. I had a case of dilated cardiomyopathy actually, no? Sa autopsy na lang pwede nating ipakita yun late in some other time, okay? Now, there are two major groups of cardiomyopathies. We have the primary cardiomyopathies and the secondary cardiomyopathies. So when we say in any disease entity, pag sinabi ng primary, ibig sabihin intrinsic to that organ. So it involves predominantly the heart, so they may be genetic or acquired. So lahat na associated with the heart itself, okay? Pero pag sinabi natin secondary cardiomyopathies, so secondary organs na, hindi sa main, okay? Hindi sa heart. So it can be involved in a systemic or multi-organ disorder such as your hemochromatosis or amyloidosis. Mayroong secondary causes, okay? Yung amyloidosis, nag-deposit siya sa heart mo, or yung iron nag-deposit sa heart mo, all right? So here are the functional patterns and causes of your cardiomyopathies. We have the dilated cardiomyopathy, hypertrophic myopathy, and restrictive myopathy. So remember, pag dilated, the left ventricular ejection fraction, since dilated siya, wala siyang power. Okay, so less than 40% yung ejection fraction niya. Ibig sabihin, ejection fraction is the volume of the blood that is ejected per contraction, per systole. All right? And then the mechanism of heart failure is that impairment of contractility. So this is a systolic dysfunction. Systole, ito yung pag-contract ng heart. All right? And here are the following. So majority genetic, no? Although this can be caused by alcohol, by certain different causes, no? Madaming causes tayo. All right? So next is your hypertrophy. Okay, the left ventricular ejection fraction is good enough, same as your restrictive, 50 to 80%. Ang compliance lang yung pangit. Okay, bakit? Kasi diastolic function, kasi remember pag diastole natin, it is when the heart excuse me. This is when the heart relaxes. Pag nag-relax yung heart, it will allow the filling of the ventricle. So kailangan natin ng madami tayong, 'di ba, pag nag-i-give tayo ng tubig, kailangan puno yung tubig natin para mabilis tayong makaligo para madami tayong magamit sa pagpaligo. So ganito din yun. Kailangan maganda yung ventricular feeling natin before mag-pump. So kung konti lang ang space mo doon, although maganda yung contractility natin kasi mapapump yung lahat, yung blood lahat, pero kasi konti lang yung feeling ng ating ventricle. Konti yung blood na makadtuto sa imong left ventricle. So ibig sabihin pangit yung diastolic function. So hindi ka din makakapagpadala sang dugo or ng oxygen ng damo sa imong organs kasi konti lang yung space niya para makapag-fill yung left ventricle. Alright? Same as your restrictive. They are both diastolic dysfunction. So restrictive kasi more on the contractility. Kasi pag nag-deposit yung amyloid natin sa ating mga myocardium, syempre hindi na siya, may dysfunction na sa contractility ng heart natin. Alright? So clear on that? Next, ito na pala. Major morphologic patterns of your cardiomyopathy. So this is the dilated cardiomyopathy. Yan, sobrang dilated niya na hindi ka na maganda yung systolic function mo or yung contraction mo ng heart. So itong sinasabi kong hypertrophic cardiomyopathy. So remember, this is the left ventricle. So malaki yung space niya kasi malaki yung space niya for blood para makapag-pump ng madaming blood sa katawan, alright? So this is hypertrophic. Konti na lang yung volume mo. So hindi din maganda yung oxygenation natin kasi konti lang yung blood na lumalabas. Although yung contractility, kasi makakapal so strong talaga yung contraction niya. Same with your restrictive. Alright? So dilated cardiomyopathy is a systolic dysfunction, while the two here, hypertrophic and restrictive, is a diastolic dysfunction. Alright? So clear tayo dyan. So next, the last topic, we have the tumors of the heart. Okay. So first is your myxoma. So remember that myxomas are the most common primary tumor of the adult heart. During my training, ito talaga yung damo talaga mga myxoma kami na kikita na specimen. So ganito yung itsura niya, no? Para siyang gelatinous na tissue. Okay? And with histologically, ito yung itsura niya. Mayroon tayong mga stellate cells na parang fibrin siya actually. Okay, so makikita mo mucopolysaccharide ground substance, yung bluish dyan, or parang myxoid, bluish, red. Although hindi ito represent, pangit itong picture na to, but this one is one picture of your myxoma. Okay, so remember that 90% of myxoma arise in the atria. So majority halos right atrial myxoma talaga. Konti lang yung sa mga left side of the heart. All right? So, tandaan nyo to, this is the most common primary tumor of the heart. Very common siya talaga. Okay, next is your papillary fibroelastomas. Okay? So, these are C. anemone-shaped endocardial tumor. So, para siyang C. anemone. Diba? Okay, so ito yung, so hindi mo malaman kung which is which, no? So, this is the C. anemone, ito yung ito yung tumor. This is the papillary fibroelastomas. Why is it called a papillary? Because there are papillary fronds. Okay, para mga finger-like projections, no, parang C. anemone nga, no? These are endocardial tumors. Ibig sabihin nasa surface lang sila makikita, all right? So these are located on valves, particularly the ventricular surfaces of semilunar valves and the atrial surfaces of your AV valves. So ganun din, just like your myxoma, para siyang myxoid or para siyang bluish yung ground substance nito. Alright? Sorry. Alright? The last tumor of the heart, we have your rhabdomyoma. So remember that rhabdomyomas, pag sinabi ng rhabdo, okay, parang skeletal muscle, okay, rhabdomyomas are the most frequent primary tumor of the pediatric heart. Okay, so pediatric heart. So kanina yung myxoma most common overall, basically in adult, kasi parang wala pa tayong, or very unusual sa pediatric na meron siyang myxoma. So most of the pediatric heart tumor, primary tumors, are rhabdomyomas. Okay. And they're commonly discovered in the first years of life during evaluation, no? Evaluation for a heart valve or other outflow disorder. Your internet connection is unstable. Can you still hear me?
Yes, sir.
Yes, Doc.
Okay, sige. So ito yung itsura ng ano natin. Itsura ng tumor natin, para siyang uterine myoma, very fibrotic. When you cut it, tan white yung itsura niya, tsaka matigas siya. And remember, this is associated with your tuberous sclerosis complex or TSC1 or TSC2 tumor suppressors. And under the microscope, okay, they are composed of bizarre, markedly enlarged myocytes with large glycogen. So ito yung mga itsura ng mga cells natin, no? Okay. So para siyang itong sinasabi na para siyang kamukha siya ng spider. Okay? These are spider cells. So, kamukha siya ni Spider-Man. Ang mga tumor cells ng ating rhabdomyoma. So tandaan niyo yan, guys. I guess this is the last topic na, no? Yun, last na yun. So, prepare for a quiz based on this lecture natin, ha? Next week.